Hello and welcome to this Chemistry World webinar, exploring AMR through a One Health perspective with insights from wastewater monitoring. I'm Natalie Starkey, Chemistry World Science Media Producer, and I'm here with you for the next hour, where we'll be hearing from two experts working on different aspects of the fight against antimicrobial resistance. Now, this webinar follows on from a special issue of Chemistry World focusing on antimicrobial resistance, which has a number of related features you might be interested in checking out after the webinar. One of these articles focuses on how researchers are innovating across different drug classes in the hunt to develop new treatments. Another asks, who will pay for new antibiotics? And you'll see that in the article, the cost of producing new antibiotics far outweighs the profit made from selling them, which is an obvious problem. We'll post a link to the special collection in the chat now, so please bookmark that for later, as you won't want to miss what our guests are going to be saying. So our guests today are Gitanjali Kapoor and Barbara Kasprick-Horden. Now, Gitanjali Kapoor is a physician with specializations in medical microbiology and public health. Currently, she's heading the India office of the One Health Trust, where she's in charge of multiple research projects in Africa and India. Her research interests include antimicrobial resistance surveillance, infectious disease management, health system strengthening, and health policy formulation. Dr. Kapoor is a strategic advisory board member for the Joint Programming Initiative on Antimicrobial Resistance, as well as a member of WHO's Bacterial Priority Pathogen Advisory Group. That's a mouthful. Now, unfortunately, at fairly short notice, we found out Gitanjali is unable to join the live session today, but luckily she has been able to record her talk for us, which we'll show prior to hearing from Barbara, who is still joining us live. So you can hear that in a minute. Now, we also have Barbara Kasprick-Horden. Barbara, if you want to turn on your camera and say hello, so people know you're here.
Hello, everyone.
Hello, good morning. It's so good to have you. Now, Barbara is a professor in environmental and analytical chemistry in the Department of Chemistry at the University of Bath's Institute for Sustainability and a co-director of Bathwater and Innovation Research Centre. Her research interests fall into three interrelated research areas of environmental, analytical and water sciences. Barbara is currently focusing on the development of early warning systems for environmental and public health assessment via water fingerprinting and wastewater-based epidemiology. So I think you'll agree we've got some really expert guests with us today, and I, for one, am really excited to hear what they've got to say. But before we hear from our experts, I just want to let you know that this session is interactive, allowing you to ask questions about any aspect of what's covered. So if you have questions specifically for Gitanjali, obviously she's not with us and won't be able to answer them live, but we will share her contact details later on in the webinar, and you're more than welcome to contact her directly. But we'll still have a live Q&A with Barbara towards the end of the webinar. So pop your questions in the chat for her and I will have a look through those and we'll see what we can get through at the end. Now, you can ask questions using the GoToWebinar platform at any time, even when the presentations are running. As a quick explainer, on GoToWebinar, there's usually a panel down one side of the screen, although this might be different depending which platform you're using, especially if you've joined via tablet or phone. But somewhere on that panel, there's a questions box, and that's where you can put your questions in. So without further ado, I think we'll get up Gitanjali's presentation, and she actually has a question for you during her presentation, which is quite fun. It's like she's here but not here. So I'll come back on to tell you how you can answer that question for her shortly. But I'll hand over to Chris, who's in the background, and he'll get the video up and running so we can hear from Gitanjali now.
Hi, everybody. I am Gitanjali from the One Health Trust India office. And thanks to the Chemistry World, Royal Society of Chemistry, Natalie, to you for inviting me on behalf of the One Health Trust. I'll be giving an overview on the One Health concept and also deep diving into what's AMR all about. So let's start. Now, One Health concept. Now, this is a concept which basically means that there is an interrelationship or interconnectedness between humans, animals, agriculture, and environment. And when there is this interconnectedness, what happens? There'll be a plethora of consequences. We just saw that in COVID. It was a zoonotic disease. Apart from that, there are many other consequences that can emerge because of this interconnectedness. For example, AMR, and I think most of us know what's AMR. climate change, food safety, and many more. And then what do you need to do? If you come up with these consequences, which are going to have a global impact, what should you do? It needs to be curtailed, right? So we need intersectoral collaboration. So that's what my slide shows over here in a flowchart fashion. What is the interconnectedness about? And that's what we mean by One Health, or the health of the planet. Now, coming to the part of intersectoral collaborations, which are important to curtail the consequences, we need that between all the different sectors: human, animal, environment, doctors, non-doctors, public health professionals, everybody, ecologists. So this is going to be a collaborative effort to mitigate these consequences. Now, coming to a little more into what this One Health is. Now, I already talked about in my previous slide that there is an interconnectedness between these four sectors. So in short, human, animal, agriculture, and environment. You can see the arrows over there. And I'll be focusing basically on the first one, that's human health. Now, also in the bottom, you can see the circle, and the circle basically tells the different components, the different consequences that happen when these different blocks, when these four blocks, they are interacting with each other. So AMR, which is antimicrobial resistance for short, zoonotic diseases, we talked about it right now. Then food safety, climate change, and health equity, many other consequences emerge. So you see, this is more like a matrix. It's more like a grid. Everything is just kind of interacting with each other. So these are the different components. You really cannot talk of one component in silo. So if you need to target for mitigating, say, for example, a zoonotic disease, or look into food safety, you have to get in touch with all the different sectors. That means human, animal, etc. Now, that's a question. Let's hear from you all. I'll give a pause after some time, but let me just go through this slide. Which of the following do you think are the One Health concerns? International travel, Ebola, antimicrobials in sewage, food poisoning, rabies, banking, or all the above? Think about it.
Okay, so we're going to pause the video for a moment there, because we'd love to hear from you as to the question that Gitanjali has posed. So which of the following are One Health concerns? Now, to put in, to give your answers to us, please use the questions box, which I realise feels a little bit weird because we're asking you to put some answers into the questions box, but we'll be able to see all those answers you've put in. If you want to just put all of the above, or if you want to say just some of those options, then please let us know. I can see some people are already responding to this question. I think it's a great question because I actually don't know. I've seen this video. When I first watched it through, I was like, I actually don't know the answer to this question. I feel like it's lots of them, but then we know it's a big interconnected world problem. So maybe it is all of them. But great. I'm getting a lot of responses here that are all agreeing, which is really interesting. So I'm going to give you a couple more moments to put your answers in. Thank you to everyone joining in. This is always a fun thing to do. Get everyone involved and get our brains going so that we're not falling asleep. I love so Mark has put an answer in. They put all of the above, and they said money is what makes the world go round. I like that answer. And then somebody else has actually questioned that they don't know whether banking would actually be in there or not. So that's really interesting. I'm going to give you just a couple more moments. I will just say at this point that all of the above is the most popular answer at the moment. But some people are thinking that antimicrobials and sewage is actually the main One Health concern. Okay, so I think we'll end there. So yeah, the consensus is that all of the above is the answer to that one. And I think we'll go back to Gitanjali now and we'll see what she has to say. Right.
So I'm sure you'll be all saying most of these, and you are correct. Banking, maybe not, right? But the rest of them, that's from international travel until rabies, these are One Health concerns. And the reasons, of course, you know best. think about it or get in touch with me on an email. I'm not there in person or live. This is a recorded video, but do feel free to connect with me through Natalie. Now, what is AMR? As I mentioned that I would be deep diving into AMR in human health. That's my area of expertise. And AMR basically means antimicrobial resistance. So here on the slide, what you see at the bottom, these are the bacteria, or you can say the pathogens. And on the right, what you see is the antimicrobials, okay? So whenever a bacteria is exposed to the antibiotic, it would naturally try to resist it. And when it's resisting to the effect of these antimicrobials, it starts developing what you call a resistance, or AMR. This is very natural, right? It needs to just defend itself. It needs to survive. And that's what AMR is about. So it can happen in any pathogen. It's not necessarily bacteria. It could be an HIV. It could be the mycobacterium, a virus, parasite, fungus. Well, these are all now emerging as important pathogens. Now, how do we quantify AMR in human health, or in any health for that matter? There are different indicators you can use. Commonly, we talk about prevalence of AMR or prevalence of resistant infections. We talk about incidence, morbidity, mortality, morbidity in terms of the quality of life or the DALYs. And we talk about economic cost, the healthcare cost, out-of-pocket expenditure, and the list is endless. You can just have a long list of indicators which basically can be used to quantify AMR in human health. How else can you quantify AMR apart from the parameters I just discussed? Well, you can see it on the slide. We can also assess AMR through what's called as the drivers of AMR. Now, what does that mean? That means what drives or what is predisposing AMR. Now, these could be various causes. It could be the patient's profile. Maybe the patient is old, maybe he's diabetic, maybe it's an infant, maybe it's immunocompromised category. So everything that pertains to the patient, his socioeconomic status, many other things. So all these are the patient level drivers or predisposing factors. Then you can also call out the institutional factors. Even these can drive AMR. An institution or a hospital which does not have strong infection prevention measures, of course, you would see more percentage, a higher percentage of resistant infections out there. So these are institutional factors. Well, I'll not be going into much detail, but I want to just give you an idea, a concept of what can drive AMR. And again, as I said, the list is endless. Then you have something which can be talked about at a national or a regional level. Now, these can be maybe the percentage of doctors in that country, or it could be the level of antimicrobial consumption in that country, how many nurses are there, what's the GDP of that country, etc. So again, the list can be endless. These are the different ways you can quantify AMR. Now, what is the latest burden of AMR globally? Now, these are all estimates. We know it's not easy to quantify such a vast and complex subject. But as per statistical modeling, which was conducted by a group of reputed researchers working for the global burden of disease, it was published in Lancet in 2022. They estimated that approximately 4.95 million, let's say 5 million deaths were associated with AMR in 2019. And of these, 1.27 million were attributed to AMR. These are just estimates, as I said, but that was based on systematic analysis. So of course, it's going to be pretty close, if not accurate. Now, on this slide, I would like to discuss about why do we think AMR is a research priority in human health. Maybe we should say why not? Because it brings about a lot of morbidity, mortality, increases the healthcare costs, right? And unfortunately, there is not enough data. There is a paucity of data, as we all know, and that's why we are here to discuss this topic. If you don't have enough data, you don't generate enough information and you don't have enough knowledge. And then how do you formulate policies? So of course you need research, and that is why AMR is an area of global health priority and a research subject. You need information, you need evidence before you can start making policies or you can decide on interventions. So what should be the goal of future research in this area? It is very clear. It is basically to generate evidence so you can decide where to make your future investments. Now, I'm not sure how many of you are aware of, but WHO's global research agenda, it has prioritized 40 topics for research. And it's very interesting. You can go on the websites of WHO, or you can connect with me. I can share that with you. It will give you a very good picture of where internationally are the stakeholders and policymakers trying to prioritize the research topic for future AMR research. Now, this picture is just like a snapshot, but you would have a very good idea of which are these research priorities. These are basically, most of them, they fall in this category. So we need to do research on the burden and impact of AMR out here, this particular subsegment. The prevention of AMR, that can be an area of research. Diagnostics, treatment and care. Then where do we invest? How do we innovate? And the intersectoral collaboration. So these all are different components of our research priorities. Now, let's get a little more into, you would ask, well, what kind of research can we do on burden and impact? You can do something like finding out the incidence, finding out the prevalence, which is standard. You can look into quality of life because of resistant infections. That means morbidity. You can look into deaths. That means mortality. You can look into drivers, which I talked about, economic burden, and many, many more indicators. These are areas of research, especially where we do not have the data. What about prevention? Can prevention be an area of research? Yes. You can look into if infection prevention control measures, are they effective? Have they been able to bring down resistant infection rates in your area, in the hospital of concern, or in a region, in a country? So these are the different kinds of research priorities. You can also look into effectiveness of vaccines in bringing down infection rates. Also WASH, water, sanitation, and hygiene. Okay. It's not so straightforward the way like I'm trying to explain, but I'm just trying to make you guys think out of the box. And of course, you can build up lots of questions. How does WASH affect the, let's say, the costing in a healthcare? So you can link economics with this. You can link sociology with this. You can look into the clinical bit with this. So it's again an endless list. What about treatment? You can also look into whether if a setup or if a hospital, it has an antimicrobial stewardship plan or program in place, has that helped in mitigating resistance, or does it need to be strengthened more, these practices? In treatment, you can also look into the antimicrobial sales in that particular hospital or consumption. Okay, so these are the different research priorities. So let's little bit deep dive into antimicrobial consumption. When there is going to be more consumption in a setup, what would happen? The pathogens, they will be exposed to a greater number of antimicrobials. There is a greater interaction, and hence there could be a buildup of resistance at a faster rate. And that's what we are actually seeing now for those of you who are coming from the clinical or from the laboratory background. You would be hearing a lot about increased resistance for carbapenems. And carbapenems is one of the very important antibiotics. If Acinetobacter starts getting, for example, resistant to carbapenem, what do you give it? Then you are left with a very limited choice. And of course, it's going to also increase the healthcare expenditure. Now, This was an overview basically about the One Health. So what did we discuss? I spoke about the concept of One Health. I spoke about how the different sectors, human, animal, agriculture, and environment, they are interlinked. I then deep dived into what are the various consequences because of this interaction. And then specifically, I picked up AMR in human health, and I went over that. Why is it an area of research? I went into that. And then I'm representing the One Health Trust, as I mentioned. And our organization also works a lot in this domain of One Health. We work across different areas, economics, epidemiology, modeling, etc. Our researchers are based across the world. And the goal of our organization is basically to tackle today's greatest challenges. We have been working for the last now almost 12, 13 years in this space. The president of our organization is Professor Ramanan Lakshminarayan. We have also been, now I'm going to talk a bit about my organization. Our organization coincidentally is also called the One Health Trust. We are a trust, and we have done a lot of research on AMR. One of them was in Africa. Over the last 4 or 5 years, we had been working in estimating the resistance rates in sub-Saharan Africa for across 14 countries. The publication would be out soon, but it was a very successful study and we had very interesting findings. So we can talk about it later. Maybe you guys can get in touch with me and I'll be happy to share this information with you. Our organization is also building partnerships with various countries, and we are trying to see how we can help them in strengthening their national strategies on AMR and then hence informing policies. One Health Trust is also a WHO collaborative center on AMR, and there is lots of work going on in our organization, especially on collecting data and visually representing it on a portal known as ResMap. Again, I'll be happy to discuss this, but this is basically an interactive tool where data from a lot of countries is available online, and you can move around, you can see, you can select which pathogen and drug is of interest to you and look into the resistance rate prevailing in that country for the labs and the centers for which we got the data. We've also developed a treatment guideline for Africa for infectious diseases. Our research is published in reputed journals, in reputed news media, for example, the Washington Post, Foreign Affairs, Nature, CNN, etc. We also publish it in high-impact, peer-reviewed journals. You can see it over here, and I'm sure most of you would be knowing about it: Lancet, Nature, Vaccine, EID, and many more. Well, that's what it is. These are our funders. We do get funding. We are supported by funding from prestigious institutions like the BMGF, USAID, CDC, WHO, MSD, Wellcome Trust, the Fleming Fund, and many more. That's my team. We work together collaboratively. We are in India, US, Africa, etc. And our new global campus is out here. You can see this beautiful picture. It's in southern part of India in a city called Bangalore. It's under construction and hopefully we should be having it up and above soon. We'll also be starting a PhD program. So it was a pleasure giving this lecture, giving this talk to all of you. I hope you found it interesting, and thanks, Natalie, once again to you and for inviting us. Happy to answer questions. You can mail it to me and I'll take it up. Thank you. All the best to all of you.
Okay, so I'll thank Gitanjali for delivering that presentation for us. As I mentioned at the beginning of the webinar, she was unfortunately unable to join us live today, but we obviously had her recorded presentation. Apologies if any of you found it very quiet. You will receive a recording of this webinar a few days after it finishes, and you could go back and watch it and possibly turn up your sound if you missed anything during that presentation. The rest of this webinar will be live, and so the sound should be absolutely fine for all of you. Gitanjali presented a lot of information there. If you do have any questions for her, please do pop her an email. She's very open to answering questions, and she can send you any of those links for particularly that resistance map. Sounds absolutely amazing. I'd love to have a play with that, so she can send you things like that. But equally, if you have general questions, we have Barbara with us as well, and she's going to present shortly. And she's actually also very knowledgeable on this subject, not just on the wastewater work that she's doing, but also on general AMR stuff. So if you have questions, please do pop those in the questions box, and I'll be able to put those to Barbara at the end of the webinar. So I'd like to invite Barbara to turn on her camera and audio now and share her screen, and we'll be hearing from her on looking into really into detail now. Gitanjali has given this massive overview of the subject, but actually now we're going to be getting into real detail about one of those research-based things that she's talked about. So hi Barbara, I'll leave it to you to take it away. We can see your presentation, so you're all good to go.
Perfect, thank you, Natalie, and thank you for a kind invitation. I'm really pleased that we can share some of our research that we do in the context of One Health and AMR. And we've just heard a really excellent talk by Dr. Kapoor, a really good one also for my own talk. Dr. Kapoor mentioned two key things that I want to take forward. One of them is we really need to gather evidence to be able to introduce interventions, and my talk is about gathering evidence and possibility of using this evidence for One Health interventions that are focused on AMR. And we also have heard about the need to understand usage of antibiotics. And again, I will talk about antibiotics mainly. I'm a chemist, so I do focus on the chemistry dimension in the context of AMR. Sometimes I tap into microbiology, but apologies if something is factually incorrect. And I'm sure we have microbiologists and people more knowledgeable than me in the context of microbes themselves. Please do correct me. So before I start, I wanted to tell you a few words about the tool that we have developed. And it's not only our group, we work across the UK and internationally to develop this tool. It's called wastewater-based epidemiology. And this is our data information knowledge gathering tool that might prove, it is already proving really important in the context of AMR, especially in the One Health dimension. So what is wastewater-based epidemiology about? I think the biggest issue in terms of data gathering when we talk about regions or cities, communities, countries, continents is that the data collection process is extremely expensive. And if you would like to have an understanding of what the majority of our communities do, we would need to collect samples from individuals, which is simply and not possible, impractical, and extremely expensive. So we have developed wastewater-based epidemiology tool with the kind of key concept in mind that we are not gathering information about people themselves. We are looking at whole communities, so looking at trends, early warning for what is happening in communities and can then be utilized to incorporate the kind of individual testing where and when needed. And I'm sure you have heard about wastewater-based epidemiology in the context of SARS-CoV-2 work. So this tool has proven to be really useful in terms of trying to understand where high infection rates were in various parts of cities or countries, and also globally. So why wastewater? We all contribute to the wastewater. So if we're exposed to pathogens, we're exposed to chemicals, internally our bodily processes will produce certain endogenous markers that we capture in wastewater via urine and feces. Obviously, all urine we call wastewater as a kind of pooled urine sample from community. So wastewater is a fingerprint of communities' health and lifestyle. And what's special about wastewater-based biology, we call it WBE, is that it is comprehensive, is continuous, anonymous, and unbiased. Everyone contributes to the sample, so and it is extremely important, near real time and objective. But yeah, WB historically has been focused on people, but we now understand that we need to go beyond people. We are part of the wider environment, and this is critical if we want to apply the kind of One Health philosophy in our thinking. So instead of looking at people, we now look at catchments, and catchments can be defined in different ways. It can be a city, it can be a sewage system if we think about wastewater only. We here tend to focus on water river catchments because they capture everything that we communities produce. So wastewater, or rather now water-based epidemiology, is an evidence tool, as I mentioned earlier on, and enabler of One Health, and it can do a few different things. One is, and this is critical for WB, is that it can evaluate environmental public health status, so collect information about the health of communities and surrounding environments. Then once the information is collected, we can draw conclusions from the data and inform One Health action and what actions. And what's critical is that WB can be used to evaluate mitigation strategies. Very often we have had, there was huge investment, one intervention happening in one city or country, and it's very difficult to gather information about whether this was actually effective. Here we have a tool that can be used for longitudinal work, sample collection on a daily basis to allow us to evaluate mitigation strategies. And we can collect samples every day simply because we collect one sample for a city, for example, a city of 1 million people, instead of million samples from individual citizens. So it is a very cost-effective tool. I always emphasize it's only one tool in a bigger epidemiology toolkit. It's an early warning. We do not identify individuals. So if we need to understand who is exposed, we obviously need to roll out individual testing. So in our group, we do tend to focus on two key tools to deliver on WB, and this is mass spectrometry, so spectroscopy-based tools, as well as we work with microbiologists and bioinformaticians. We gather data from, for example, sequencing. And this is our core information. They all are taken from, data is taken from wastewater. And we then draw conclusions from the data we get. We do time series, so longitudinal studies. Some of the cities we studied for 3 years now. And this is really powerful tool because we can understand longitudinal changes, chronic conditions. But of course, sequencing mass spectrometry on their own won't provide us with the kind of holistic evaluation of public health issues, and will not allow us to identify risk and manage. We really need to tap into other resources, and this is where One Health comes into play. We do collect and do data triangulation with epidemiology data from, for example, public health organizations. We also tap into socioeconomics, demographics. We do modeling. So this all is really needed to fully appreciate the data that we get from wastewater in the first stage of our work. And so it's not only different types of data, it's how much of data we can collect from one particular sample. We don't focus on 1, 2 chemicals. We do hundreds and hundreds of analysis of hundreds of chemicals. Each of these chemicals will give us its own story. And this is just a snapshot, one type of work that we do. And my intention is for you not to read this text. It's just to show you the quantity. We look, for example, at antibiotics, the topic of today's discussion. But also we know that antibiotics are not the only factors that we need to look at in the context of AMR. We also have to look at other co-selecting chemicals, such as other pharmaceuticals, some wider contaminants, and we capture them all. But here is the list of antibiotics that we focus on, the ones that are most widely used, the ones that are of more of importance in the UK. And I will focus my talk on the UK mainly today, but I'll also give you a snapshot of international work that we've done. Our great collaborators, Stellenbosch University in South Africa, when we focused on studies there. Hence, we have a kind of good spectrum of pharmaceuticals, antibiotics that are used to treat tuberculosis. So this is a typical result of our work in terms of graphical representation. So we work at the catchment scale. Here we see, apologies, this is the River Avon. The Bath is here, where I am based. University of Bath is based here. River Avon is the southwest of England, and we wanted to understand various different factors that contribute to environmental burden in this particular river. Antibiotics are a key component of this, but just very briefly, I will give you a snapshot of what else we can see, and then I'll move to antibiotics afterwards. So key to success in collecting data is to know how to sample, where to sample, and what to sample, and it takes a lot of time. We want to make the process as comprehensive as possible, but also financially viable. So what we try to do in this catchment, we try to capture as many people in the community as possible, and we managed to do it by focusing on wastewater treatment plants from 5,000 cities, and they're mentioned here. So this is WWTP, A, B, C, D, and E. And they all are about over 1 million people, and they constitute over 75% of the population. So we captured, by sampling at 5 treatment works, 5 samples a day, we get an understanding of 75% of people living, functioning in this particular catchment. We also looked at the river points after, before and after discharge points, and these are S points, S1 up to 8. And this is the environmental burden coming from communal discharges into our river. And these are the typical pie charts that we produce. So this is wastewater influent. We have a certain makeup in terms of percentage contribution of chemicals, lots of lifestyle chemicals, mainly caffeine, nicotine, anti-inflammatories, anti-diabetics. This is mainly metformin that is used in huge quantities. This is wastewater influence. So information gathered here informs us about public health, okay? Wastewater is a pooled urine sample. Now, we also look at the receiving environment, and you can see the makeup, chemical makeup is different here. And this is because there is very effective wastewater treatment process in place. Still, we managed to capture some of the chemicals in our rivers. And one of the groups, antibiotics. Antibiotics constitute about 1% in wastewater influent of the overall chemical makeup that we captured, 141 chemicals. But they become almost 10% in effluent. That means that the wastewater treatment is not really as effective. This might mean a problem down the line in the context of AMR. So that you must have heard about the kind of environmental hotspots, and wastewater treatment is considered to be one of those for AMR. So what we tend to do mass balances. We want to understand of where problems and issues might be at the catchment level. So for this particular study, we managed to capture about 170 kilograms of various different chemicals per day. Most of them have been removed. Only 14 kilograms have been discharged into our river. Unfortunately, antibiotics were part of this 14 kilograms, and we managed to gather evidence that these antibiotics, even if in very low quantities, exceed PNEC values. PNEC is predicted no effect concentration. For environmental effects, these are mainly ecotoxicological effects like growth, reproduction, and death, as well as important for AMR is MIC, so minimum inhibitory concentration. And this raises concern. We have evidence that something needs to be done in the catchment to reduce environmental issues. So what we have seen when we look at our river and river flows in this direction, and this is the city of Bristol, and it goes in this direction here on those graphs. And we have various different chemicals here. Again, I'm not going to focus on those. Just look at what happens with the flow of the river. The daily loads, milligrams per day of various different chemicals go up. And they go up because there are more people down the catchment. So when river flows through various different cities, it just collects all the waste that comes from cities. Even if extensively treated, we still see that the kind of the accumulation of contaminants. But what we have found out was really interesting and intriguing, and actually it triggered some further thinking, is that no matter where we are in the catchment, whether we are in city A or in city E, we produce per capita, discharge per capita, 154 milligrams of chemicals that we studied per day. And the standard deviation is very low. It's plus minus 20 milligrams, 12 milligrams, and this made us think that okay, if we are so predictable as a community across the catchment, this means that we are the driver for contamination here. Okay, so understanding the drivers is critical in terms of the deliver successful intervention. So in this case, if we are the driver, we need to look at either technological solutions, they are costly, and there is also an issue with technological solutions when it comes down to end of pipe treatment. They are carbon energy intensive. So we are then hitting another very important challenge, which is climate change. So in our local work with Wessex Water, which is our local water utility that is in charge of this Avon catchment, we are looking at changes that are needed at source, which is in our household. So for example, can we introduce some kind of educational campaigns? Can we work with GPs, maybe introduce social prescribing instead of yet another pill as a result of a visit to a GP? So these are the things we are looking at. So technological solutions are not the only one. We have also societal and policy changes that we can look at. But what I would like to emphasize again, we need to have evidence to be able to drive the change. So very quickly, the same catchment, the same work, is just focusing on antibiotics and resistance genes. And please remember, I am a chemist. So what we looked at in our catchment, we wanted to see the kind of general thinking is whether there is a correlation between antibiotics. So if there are more antibiotics, is there also the higher prevalence of AMR? And we looked at selected resistance genes as proxies for AMR. So we looked at sulfametoxazole and SUL1 gene, chloramphenicol, CAT-A, microlides, ERMB, and fluoroquinolones QNRS. And we did some quick statistical analysis, Pearson coefficient, the higher the number, the better the correlation. So what we could see that antibiotics correlate really well with resistance genes. And we actually see it very nicely in these two graphs. So we have 5,000 cities, and we see then city E, which is the city of Bristol. We have the highest daily load of antimicrobial agents. Also, we have the highest daily load of gene copies per day. Now, the second city with the highest load is city C, which is Bath, where I'm based. Again, you can see it has second highest load of antibiotics as well as resistance genes. Now, when we normalize daily loads to number of people in individual catchments, you can see these values plateau. And this made us think that the biggest driver here in terms of those daily loads is actually number of people in the community. There is a little bit of a change here. These are two different regions in terms of local authorities. City A and B, this is Wiltshire. City C, D and E, it's Somerset. Maybe there are differences in the way GPs, general practitioners prescribe antibiotics. Okay, something that we need to look at. But we also actually have found very similar outcome in our European work. We work with various people across Europe, collected information about, again, antibiotics and resistance genes, and we found that Milan has the highest level of antibiotics as well as resistance genes. This is daily load. But again, don't be fooled here. Milan also is the largest city out of all that we studied. When we normalize the population size, we see that actually usage of antibiotics is the same as in Castellón, which is a Spanish city. And this also nicely corresponds with resistance genes. We all know that in the southern part of Europe, we have high usage of antibiotics as a result of resistance genes, while in northern part of Europe, this usage is lower. And our data generation tool, which we call WB, has proven this. But we have always been curious about, this is all spatial work, so short-term studies, 1 week here and there. We really wanted to have an understanding whether there is true correlation in one particular community with antibiotics usage. And this is critical if we want to introduce interventions. So we all say, too many antibiotics we use, we really need to reduce antibiotics usage. If we reduce, we'll see a reduction in AMR prevalence. We tried to see it in our work. So we did 3 years worth study. Here we have only 1 year captured. We collected samples every week for a long period of time, and this is one city. We did not did for other cities. This is city of Bath, and what you have here, the blue color is this antibiotics, so macrolides, sulfonamides, quinolones. Orange color, these are metabolites. The orange color is very important for us because it tells us when antibiotics were consumed. or directly dispose of. It's incredible to realize how often we all dispose pharmaceuticals down the drain. We should not be doing this. Now, the dark dots, black dots, these are resistance genes. What we wanted to see is a nice correlation. As antibiotics go up in winter, resistance genes go up in winter. We did not see it. Of course, I think we wanted to see too much. Antibiotics go up and down. They are not persistent in the environment. They get broken down, and they are very much season-driven. Now, resistance genes, once microbes get resistance mechanism, they don't get rid of them on a daily, monthly, or annual basis. So I think there is a challenge here in terms of working with communities where there is already high level of resistance. But again, we still need to focus on the reduction of antibiotics usage. So what we also have tried to do is to have an understanding whether our tool is fit for purpose. It can help us with understanding of prescribing. I've already mentioned the idea of being able to capture down the drain disposal of sometimes a few hundred pills go down the drain by maybe one household, maybe GP surgery, and maybe a hospital. We don't know. As you know, we work at the community level, but this is happening. And again, we need to roll out educational campaigns, and we are planning to do those in our with our local authorities in due course. What we try to show here is how our data, wastewater data, and these are the dots. Blue dot again is the parent compound, orange dot is a metabolite, various different chemicals. Again, no point in reading what they are. I just wanted you to see trends. And this is one you will study, so you see they go up and down. The blue color beyond the dots, this is prescribing. We have NHS data monthly prescribing in our catchments, and you see that what we see in wastewater does not necessarily, this is the only actually chemical, this is clarithromycin, correlates well with prescribing. Other pharmaceuticals do not. And the question is whether it's the prescribing rate is different. Maybe we stock up, maybe we don't comply. Again, something that our tool enables us to understand. We need to work with GP surgeries to understand why there is no compliance with pharmaceutical prescription. What is more troubling for us is that we can see other antibiotics, antimicrobial agents in our catchment that are not officially prescribed, so they're not present in statistics. And we have, for example, TB drugs present in our catchment, and there is no official mention of those being present. So they might be brought into the catchment from somewhere else, or obtained in different ways. Again, WB enables us to understand what's happening in the catchment. Now, one of the things that we need to look at when we think about antibiotics is what does this mean for the environment, not only on us, our health, but also the wider environment. So what we have done, we looked at wastewater, and actually we looked at community wastewater, and this is the kind of the two pie charts here. And we also look at hospital wastewater. We try to understand whether there is a consequence of the presence of antibiotics and resistance genes in wastewater from these two contrasting communities with the kind of wider environmental impact. So we compared concentrations, and these are concentrations, average concentrations of antibiotics. They're present here in hospital wastewater versus the wider community. And please bear in mind that hospital wastewater ends up in community wastewater and actually contributes very small percentage overall. So we have a hospital in the city of Bath, and the city of Bath itself is a large city of 100,000 people, or maybe medium size. Now, we also looked at predicted no effect concentrations, so MICs, minimum inhibitory concentration, so this is the AMR dimension, as well as environmental impacts. In order to see whether this wastewater might carry a problem. And you see how much more of a red we have in hospital wastewater. This is because we have higher levels of antibiotics in wastewater. So wastewater is not diluted by other activities in the catchment. So here there is a hotspot for potential AMR development. But we also see this in the community wastewater. Of course, this wastewater is going to be treated and then released into the environment. But again, you must have heard about the frequent instances of the discharge of untreated wastewater during sewer overflow events. And of course, this is much more important problem in lower resource settings when there is no wastewater treatment. So something to really bear in mind. Many pharmaceuticals are present in wastewater and might be triggering resistance. We need to really think about solutions in terms of mitigation strategies. And I would like to emphasize again, these are not only technology-driven mitigation strategies. I think this is my final slide. I wanted to give you a little bit of a flavor in terms of our international work. We have an amazing collaboration with our partners in South Africa, Stellenbosch University, Professor Gideon Wolford, a microbiologist, conveniently so, because I'm a chemist. We had several projects, UKI funded, trying to understand the river as the catchment. Stellenbosch is an interesting city, beautiful city, but also full of contrasts in terms of infrastructure, rich area, as well as very large informal settlements that are not connected to infrastructure. And the city of Stellenbosch is also similar in size to the city of Bath. So we did comparison in terms of kind of low, high resource setting as well as lower resource setting, with a huge problem of thousands of people living in communities that are not connected to the sewage system. And this is just a snapshot. We published 2 papers. If you're interested, I'm very happy to share. And actually, every slide had a paper linking with the work that I discussed today. And I'm more than happy to share all those papers. Just please email me. We looked at Stellenbosch, the river Elster, as I mentioned. It starts its flow in the mountain area. It's pristine, and this is point A, 1A, no antibiotics, beautiful. And the river then flows through informal settlements, and then it flows through the city. And there is a discharge point from treatment works. This is WWTP here, and then it flows further down. What we could see, and this is totally different to what we see in the UK. In the UK, the biggest issue is the communal discharge of treated wastewater in terms of contamination. Here we have, and this is the pristine area. Then we are hitting 2 sampling sites that are part of informal settlements. You can see huge daily loads. These are daily loads, and this is average value for 1 year worth monitoring. So this is not one snapshot work. This is 1 year monitoring. We have high quantities of antibiotics being released from informal settlements. There is no treatment in that. This is the problem. And this is wastewater influent and effluent. And then we see points down the river. So what we actually see is that the wastewater treatment that is in place, and it's a new process, membrane process, MBR process driven, actually is doing the job in terms of the removal of antibiotics. You can see there is very little here in terms of effluent. So it's interesting situation that we see here is that effluent wastewater from treatment plant makes the river cleaner. It dilutes the waste coming from informal settlement to give better overall ecological status down the line. So it again provides us with good information. Yes, technology is resolving a problem, but of course, if there is no treatment in place, maybe there need to be other strategies implemented to enable this. And this is also my last slide in terms of summarizing what WB is about. It's an evidence gathering tool that can provide us information about usage of pharmaceuticals in the region, and it's independent on prescription, is independent on compliance, independent of movement of people. We just capture information as it is. We have managed, by comparison of 2 contrasting cities, Bath and Stellenbosch, see that the usage of pharmaceuticals is different in both locations, and we know that for sure across the globe. But this is very important in a way that if we are to introduce management strategies, intervention strategies, they need to be region driven. They need to be the needs of local communities driven. And I will leave it with this. Of course, I would like to thank all the funders, UKRI, European Commission, water utilities, especially our long-standing partner, Wessex Water, as well as many collaborators across the board internationally, and especially our environmental chemistry, public health research group. These are PhD students, postdoctoral researchers, and wider academic groups at the university and beyond that contribute to this work. I'm only the messenger today. Thank you.
Wow, thank you so much, Barbara. That was fascinating. I had no idea that you could really trace all of these chemicals in the water. It's just amazing. That table you showed, obviously we couldn't see all the words on it, but I was like, oh my goodness, we can really see, all of those things are in the water. And one of the questions that was coming up in my head as we were watching that, you looked in detail at this Avon region, how much did that apply, to the rest of the country, the rest of the UK, and then globally? And as we've seen, actually, it does seem like, in a way, you can just extrapolate those findings, although you probably would want to do more studies in more cities to build up that picture. But one of the things that I thought of in terms of the South African example you've just gone through, and the wastewater treatment working well, how different is the technology in countries, or within a country, or even across global settings?
Oh, it's just it's incredible how different it is. In infrastructure-rich settings, we have most of wastewater treated. It doesn't mean that it's treated very well. There are 3 types of treatment. So there is this primary, secondary, tertiary treatment, and depending on where we are and what kind of investment then there was and when the investment took place, we will have different efficiency of the treatment process. The example from Stellenbosch is an amazing one, and we were so impressed to see that MBR, a few years old, wastewater treatment process, has done this amazing work. In Bath, we have well over 100 years old treatment process in place, still very effective. It removes a very high percentage of chemicals, but we see the difference in terms of we have treatment filters versus the kind of enclosed modern MBR treatment. But there are places in the globe that have no treatment whatsoever, and this is where the biggest issue is in a way, because we are not capturing antibiotics as well as other chemicals that get through to our water courses. And there is enough evidence already that indicates that we should not be focusing on antibiotics only when we think about AMR. We need to be looking at other chemicals that might be co-selecting for resistance. So a lot to be done. And again, I've always been a believer in technology. I'm a chemist, but with AMR there is a little bit of a problem, because we need to reduce antibiotics to very low levels, also the chemicals. And then we have this overarching issue of climate change, and all these beautiful technology-rich processes, unfortunately, are also energy rich, require energy input. So we need to make a balance between investment in new technology or develop technologies that require less energy input. I think this is the way forward. But also look at this reduction of usage, so at source solutions. And this is something that we communities can do. We don't have to just wait and see what the investment is going to be. We can take an action now.
Completely, and that's just this One Health approach, which I understand now is so important, because it's just a bigger problem than just looking at what's in the wastewater or how we prescribe. It's a much bigger problem. We are a bit short on time, but I'm happy to run over a little bit. So if the audience are able to stay on the call, that would be great. If not, you can always come back in a few days and watch the recording if you miss any of the questions we go through now. One question from Camilla, which is a great question. Were you able to look at antibiotic use in veterinary medicine? Because I was thinking that Avon region, I know it well, it's quite rural in places. You've got big cities like Bristol and Bath, but then you've got a lot of rural settings. So how do you know how that influences your overall findings?
So this is our project that we have already started. We don't have enough data. So we moved, if you remember earlier, I mentioned that we focus on wastewater, and now we're looking at whole catchments. So we have done first a sampling campaign over summer when we looked at other potential contributors in the catchment. So this is livestock, veterinary usage, as well as wider agriculture. So this is data that is being produced as we speak, and maybe if there's another talk at one point in the future, I'll be able to share. But yeah, a very, very important point. We need to go beyond communities and understand other contributors, drivers in the catchment or any catchment.
And I imagine there's some overlap in the types of antimicrobials used in animal populations and human populations. I'm not sure if you know anything about that, but how is there a way to pick that apart in any way?
So yes, some antibiotics are used in both livestock and human treatment. Others are more for livestock usage. We should be able, because, and again, it's down to sampling. The way we design our study, we should be able to pick up where pharmaceuticals, antibiotics come from. So yeah, this can be done.
Can be done. That's amazing. A question from Hector, really specific about your sampling. So she said you got 5, or they, sorry, have said you got 5 samples per day from 5 different sites. They're interested to know how long. So you mentioned it's a longitudinal study. You know, how does that work? How long has it been ongoing? And are you really collecting 5 samples a day from 5 sites? Because that sounds like a lot of work to me.
Yes. So what I did, I just mixed 2 different studies. So the 5 cities, we actually had this kind of intensive 1 week worth sampling campaign. So we collected samples over 7 days just to get the week worth, weekend versus weekday comparison. Some cities we focus on sampling for longer periods of time. So we have 4 locations when we sample on a regular basis, not every day. During SARS-CoV-2 pandemics, we sampled twice a week. And this is a kind of nice default decision that we made in terms of with 2 samples per week, we can capture changes within community. We don't need to sample every day. So it really depends on the question in the study. Are we doing spatial? We have to do very high resolution, so daily samples, composite samples, so we collect 7 days worth. And we still do it for our European studies that we undertake every year. But if we want to understand fully how community operates, we do 2 samples per week over 3 years' time, and we do this. We wouldn't be able to do it without support from our main collaborator, wastewater. They are the ones collecting samples and bringing to our labs. So a big thank you to them again.
Oh wow, okay. I was wondering how you did that, how you managed that with resource, because obviously that's a lot of sampling. Yes. And it just it's an incredible amount of data as well. You know, you must handle a lot of things. So yes.
We are overwhelmed, I must say.
Yes, I can imagine. We've got a question from Lindsay asking, did your studies also look at the differences in concentrations due to stormwater and releases of untreated wastewater from combined sewers?
So again, this is something that we captured in our most recent campaign when we moved away from wastewater treatment works and look at the whole catchment. So we had actually managed to capture really heavy rainfall, potentially the CSO wastewater release event. We'll see. We are working with the data.
Okay, brilliant. Let me go on. Right, we've answered that one. Brilliant. So some people ask very similar questions, so it's great. I can kind of cover off 2 questions at once. Let me see. So yeah, one of the questions I wanted to move on to a bit wider, because we've done quite a bit of detail on your sampling and the strategies you're using. How do you kind of feed into this kind of policy and wider impact of your work in kind of the One Health approach I'm kind of asking about? How do you feed into that? How do you report back these findings, apart from obviously publishing them in journals and things?
Yeah, we do publish, but I realize that publishing is really not the way forward if you want to progress, if you want to make sure that the data they produce can be uptaken into policy making. We work very closely with local government. We work closely with the UK government, UK HSA, so UK Health Security Agency, as well as we are part of networks. So, for example, Nomen Network that closely links with the European Commission. So there are channels when we try to disseminate information as much as we can, doing a lot. We should be doing even more. And I actually had discussions with representatives from local government not long ago that there is a need for more information. So there is a willingness to receive more information from the government, which is amazing. So we have the dialogue ongoing, which is amazing.
And I expect, I mean, it's a surprise to me to see these results, and so I expect it's also a surprise to them. I expect, you know, these policymakers and local government probably weren't aware of what the size of this problem is, and I guess it's very useful for them to see that data. And I'm wondering how, have there been any changes so far? I realise you're kind of young in the studies at the moment, and it's quite new work, but have you seen any changes across the board?
So one of the things we want to do in the context of today's discussion, so is the One Health and not only AMR, but the general pharmaceutical usage and there is a lot of work happening in local government in terms of introducing social prescribing in a way as a way to reduce pharmaceutical prescription, which is a big issue down the line in terms of water quality, but also pharmaceuticals are the biggest are linked directly with huge carbon footprint when it comes down to National Health Service. So there is this dialogue in terms of how local communities can take data forward, and actually how they can use our tool in terms of capturing the effectiveness of interventions. So we had some projects ongoing, new ones are being planned, focusing on certain areas, the most deprived communities in our southwest of England. So yeah, work is ongoing. So the data is being used to introduce interventions, which is amazing. Again, maybe we need a little bit more time just to see whether we can capture the change. Fingers crossed we can.
Definitely. And then, yeah, obviously, as you said, we need to think globally as well, because, not everywhere has the same wastewater handling, and there's a lot of problems to look at. So, well, I think we're going to call it a day there. We've had loads of brilliant questions. If you have any other questions for Barbara or indeed for Gitanjali, please do get in touch with them. And, that's been an amazing discussion. I've learned so much today. So thank you so much to Barbara and to Gitanjali for talking to us today about the One Health approach and some of this work that's being done on wastewater monitoring, which hopefully is going to start tackling this big global problem of antimicrobial resistance. And also thank you to you, the audience, for getting involved in the conversation today. We've had some fantastic questions. I hope you've enjoyed what you've seen and learned more. And remember, you can rewatch the webinar in a few days when you get the recording if you missed anything, or you can indeed share that with friends. Now, if you've enjoyed this webinar, please do check out chemistryworld.com/webinars for future events. And while you're there, you can feel free to register for a Chemistry World account, where you can sign up to our very popular reaction newsletter, which includes a weekly digest of big stories from across the world of chemistry. Now, I'm Natalie Starkey, Chemistry World Science Media Producer, and I really look forward to seeing you again in a future Chemistry World webinar. Thank you.